We are
Good evening, all from India. Today, we are here for the AIOS IOC 2024, the curated best of knowledge from right across the globe for the North American Neuroophthalmology Society session. I'm your host, Dr. Sabah, for this session, and we have our moderators, Dr. Rashmin Gandhi and Dr. Madhvi Bijlani, to take over the session. This is how this session will unfold. And may I now request the moderators to please take over and introduce the chairperson for today.
Thank you, Subhav. Thank you so much, and welcome to this interesting session in partnership with Nanos. We are really honored to have our faculty and our panelists here. And we are joined by my co-moderator, Dr. Madhvi Bijlani, who will be conducting the session. Over to you, Madhvi.
Hi, thank you so much, and a very good day to all. I'm Dr. Madhvi Bijlani from Mumbai, and thank you, Dr. Rashmin. Our chairperson for today's session is Dr. Prem Subramaniam. He's going to be joining in a little late. He's the current president of Nanos and heads the ophthalmology, neurology, and neurosurgery units at the University of Colorado. I'll move on to introduce our panelists for today's session. We have Dr. Claire, who has joined us. Dr. Claire, could you unmute yourself? And can you hear us?
Yes, I can hear you. Lovely to be here. Thank you so much.
Hi, thank you for joining us. Dr. Claire is here from Safe Sight Institute at University of Sydney, Australia. And our other panelists are Dr. Rohit Saxena, Dr. Ambika, and Dr. Murlidhar, who will probably be joining us shortly. We have Dr. Jaspreet Sukhija with us. Sir, could you please unmute yourself?
Yeah. Hello, everyone.
Hi, sir is here from the Advanced Eye Center, PGI Institute, Chandigarh. We also have Dr. Ramesh Kekunya with us. Sir, could you unmute yourself as well?
Yeah. Hi, everyone. Nice to be
Hello.
here.
Sir is joining us from the KAR campus of LV Prasad in Hyderabad. So thank you all for being with us in this session today. And let's begin our session. And we'll learn what's new in neuro-ophthalmology in 2024. Our first speaker for today is Dr. Susan Mullen. I'm not sure if she's joined as yet. No, she's not here.
I've just had a message from Dr. Mullen. She's joining in a few minutes. So perhaps if someone else online is able to start the session, that'd be good. Thank you.
Okay, we could do that. Dr. Stephen Haman, are you around? Can we start with you if that's okay?
Yes, I am. No problem.
Thank you so much. Dr. Stephen is, I hope I'm pronouncing your name correctly.
Stefan.
Stefan, I'm sorry. Okay, he's
No problem.
joining us from the Copenhagen University Hospital in Denmark, and he'll be discussing multimodal diagnostics in giant cell arteritis. Over to you, sir. Please share your screen.
All right. Can you see my screen, everyone?
Yes, Stephen, we can. Thank you.
Perfect.
Thanks,
All right.
Stefan.
All right. Thank you very much. Claire, are you still on? Can you please unmute? Thank you very much. And I'm going to speak about multimodal diagnostics in giant cell arteritis. So this is a disease which is autoimmune, inflammatory, and granulomatous, and it affects the medium and large vessels. It is a clinical emergency as it can cause blindness due to AION, and it can also cause stroke in about 5% of cases. It usually affects the cranial arteries from the carotid artery, but extracranial involvement known as large vessel TCA has been described in up to 80% of cases. So large vessel TCA affects the aorta and the main branches with the risk of aneurysm, dissections, and valvular heart disease, whereas the cranial type gives a classical headache and jaw claudication, etc. There's a close relation between TCA and polymyalgia rheumatica. So this is the picture that we fear as eye doctors. A patient comes in with an arteritic anterior ischemic optic neuropathy with severe irreversible vision loss and a palate disc edema looking like this. What happens anatomically is there's an occlusion of the short posterior ciliary arteries, But you can also in GCA get a central retinal artery occlusion, and in rare instances, you can actually get an ophthalmic artery occlusion. So these are the risk factors. This is a nice diagram from Professor Mullen. And by far the most important risk factor is age. This is a disease of the elderly population. You only see it in patients above 50 years old. And in our cohort, the average age is around 75 years. It's mainly patients of Northern European ancestry and mainly female. So here you can see how the incidence varies tremendously across the globe. It's called a Viking disease. So where I'm from in Denmark, the prevalence is quite high, and the incidence is measured to be around 22 per 100,000. In the Indian subcontinent, it's unknown the prevalence and incidence, but it's rare. Treatment is with high-dose corticosteroids, which should be commenced immediately on suspicion of disease, and a subsequent confirmation is essential. So diagnostic suspicion is raised if you have the relevant age group, you have the characteristic symptoms, and elevated biochemistry with CRP and platelet count. You don't need to wait for the sedimentation reaction, which was classically employed as well. It doesn't really add. We've shown this in a recent study. And in recent years, tocilizumab has been introduced and may allow for quicker steroid dose reduction. So this disease was first described in the late 18th century, but it has most certainly been around for a much longer time. And why do I show this picture is a very nice painting from the Dutch painter Jan van Eyck, who did this painting in 1436. And it shows the Canon van der Pijl, who suffered from a mysterious illness with prominent temporal arteries, and it was probably a temporal arteritis. So I'll just do a brief historical recap. In 1890, Hutchinson gave the first clinical description of the disease, and in 1930, Schmidt reported a patient who probably had it as well. The problem here was that none of these took biopsies. Then forward to 1932, where Horton reported the first two patients he'd seen with biopsy affirming granulomatous arteritis. This is actually a drawing from his first patient, a female, and this is his lab notes with an elevated sedimentation reaction. In the following decades, there were many detailed descriptions of AION in the context of GCA, and then we fast forward to 1995, where Schmidt and colleagues introduced for the first time the use of color duplex ultrasonography of the temporal artery as a means to diagnosing GCA. And now the story of multimodal imaging begins. So why is GCA diagnosis that important? Well, it's a medical emergency, and there's a risk of blindness, there's a risk of stroke, and actually if you get an AION, up to 50% will have it in the fellow eye within 2 weeks if untreated. How is it made, the diagnosis? Well, I've already mentioned the demographics, the clinical presentation, and the biochemistry, and also the temporal artery biopsy, the TAB. But we also now have systemic imaging, ultrasound, PET-CT, MRI, and some ocular imaging. And I will focus on these 4 ones here. Just a brief mention of the temporal artery biopsy. It has been around the time of Horton, almost 100 years. It has been globally accepted as the gold standard. The sensitivity varies a lot. Of course, the specificity is very, very good indeed. The problem is it's an invasive procedure. It's only good for the cranial involvement. And as I told you, you also have a large vessel component. And there is a high risk of false negatives, and it takes several days for the results to come out. And actually, it's also interesting to see if you take, for example, 14 pathologists here, and show them biopsy specimens, you have a lot of variation indeed. So we move on to look at ultrasound. And the halo sign, the wall thickening in GCA, it was first introduced in 1995 and published in the New England Journal of Medicine in 1997 by Schmidt and colleagues. And since it has been supported by 5 meta-analyses, yielding an overall sensitivity of up to 88% and a specificity of up to 91%. Also in 2013, the compression sign was introduced, So it signifies persistent visibility of the temporal artery upon compression of the artery with the ultrasound transducer. As you see here to the right, in the patient with GCA, it's impossible to compress the artery, while in a normal patient, there's no problem. And it has a very high positive predictive value for GCA diagnosis. The largest study that was made of ultrasound versus TAP came out in 2016. It's called the TABUL study. It involved 381 patients, and the sensitivity of ultrasound was 54%, specificity was 81%. The TAP sensitivity was down to 39%, but the specificity again was very good, 100%. Then they employed a combination strategy where they did ultrasound first and then TAP in sequence if ultrasound negative. This raised the sensitivity to 65% and the specificity remained at 81%. So the conclusion of the TABUL study was that only in cases of high clinical suspicion of GCA and a negative ultrasound should a TAP be considered. We recently did a retrospective study of our cohort looking at 78 patients suspected of GCA, where both ultrasound and TAP was performed. And we found that these two modalities had an equal sensitivity, and the specificity again was a little higher in the TAP group. Okay, so PET-CT, the use of PET-CT in GCA, it leverages the ability of FDG, which is a glucose analog, to accumulate in metabolically active cells, including the inflamed cells of the arterial walls, which is characteristic of GCA. It has actually been used for this purpose since the early 2000s, but now more and more. The sensitivity and specificity are quite high, and this rapid imaging technique visualizes the whole artery tree in a single scan, which is very nice. And this is an example of a case that we recently published with vertebral artery involvement solidly, which is the reason why the patient had a negative biopsy to start with. Okay, so recently we introduced a novel modality. It's MRI, but it's so-called black blood MRI, where we use 3D high-resolution T1-weighted images to suppress the signal from the flowing blood. And this allows a clear visualization and characterization of structures that are juxtaposed to the blood pool, for example, the vessel wall. And we did a comparison of findings on black blood MRI with PET-CT in 10 patients suspected of having GCA, and there were full consistency between the two modalities in all 10 cases. And here in the gray tones, you see the black blood MRI, and the colored ones are the PET-CT. And here are some examples. You see in A, it's a patient with a left occipital artery involvement. You can see it in both modalities. Here, this patient has a right temporal artery involvement, and this patient has bilateral occipital involvement. So it's a very nice technique. It has the potential benefits of providing high-resolution images with a full coverage of the cranial arteries. Often it's available, it depends, of course, where you are. It's a very short scan time, only 8 minutes, then you have the answer, the diagnosis or not. There's no radiation, there's no contrast agent provided. And compared to ultrasound, the vertebral arteries are easily identified and well visualized. Furthermore, it can be performed in conjunction with PET using PET MRI, and that will probably be the future. Finally, I'm just going to mention the OCT. And we did a study based on some recent findings showing that the PAM, the paracentral acute middle maculopathy, which has been described in some retinal vascular disorders, it's also seen in giant cell arteritis. And then in NION, there's sometimes intraretinal and subretinal fluid. So we did a study where we wanted to look whether we could use PAM and intraretinal subretinal fluid to differentiate the arteritic form of AION from the non-arteritic form. And we did it with 10 patients with AION and 25 with NION, and the macular OCT were graded by 2 independent graders. Here are some examples. This is a patient with AION, and here's a patient with NION. So here you see the PAM findings, and here you see the intraretinal and subretinal fluid. And we saw PAM in 6 patients with AION and in none of the patients with NION. Conversely, a lot of patients with NION had intraretinal and subretinal fluid, but it was very rare in the AION. These findings had high sensitivity and specificity, and we concluded that the PAM is a marker of AION, and the fluid extension to the macula is a marker of NION. And if you use these two modalities in combination to look for it, you actually can place the diagnosis of AION, arteritic AION, in up to 77% of patients. So what are the current diagnostic guidelines? The answer to this is it depends very much on where you are in the world. And in the US, it's still pretty much the biopsy that is prevalent. It's also prevalent in Europe with the biopsy, but here you also have a lot of centers now implementing fast-track clinics for doing ultrasound and additional imaging methods. And this is mainly based on the EULAR guidelines that were recently updated last year. And now first line, where you have a suspect of GCA, is to do some kind of imaging. You need high expertise and a training of the personnel. And in patients where you have a high clinical suspicion of GCA and a positive imaging result, there's no need for doing a biopsy anymore. And what they also recommend is that the ultrasound is first line, and then you can add different modalities as well. And we're currently working on a GCA diagnostic flowchart algorithm, which is based on results from an ongoing clinical trial that we're doing. But this will probably be pretty much consistent with the EULAR 2023 recommendations. So take-home messages is that the traditional TAP is currently being replaced by non-invasive imaging modalities that are at least as accurate and that provide more rapid diagnosis, which is important in guiding treatment. The imaging modalities recognize the fact that this is a systemic disease. It's not only confined to the superficial temporal artery where the biopsy is handy. And OCT is currently being refined as a rapid means to distinguish the two types of anterior ischemic optic neuropathy from each other. And GCA, finally, it's a heterogeneous disease. It has a multitude of phenotypes, and this will benefit from a multimodal diagnostic approach. I'd like to thank my research group and the main local GCA research collaborators, and thank you very much for your attention, and I'll be happy to take any questions.
Thank you so much. I would like to invite any questions from the panel. And we also have our chairperson for today's session, Dr. Subramaniam. He's just joined in. Hello and welcome. Could you unmute us?
Yes, hello everyone.
So can I ask a question, Stefan? How often would your institution now be doing temporal artery biopsies, or is this now a dying art form given these other accessible vascular imaging techniques?
Right now, we're like in a transition period. Until now, we've been doing the biopsy almost every time because we haven't really looked at all our results from our ongoing study yet. We're doing a large study that we just concluded inclusion here by end of December, and we're looking at the results from that. But we're probably not going to wait until all the results in doing an algorithm. And so I think you're asking the question right in the transition period, but I think if you ask the same question in a month, I think we'll only be doing biopsy in selected cases. But right now, I would say we probably do it most of the times, just to be sure.
And in your institute, is that causing any, would that potentially cause any issues with long-term steroid treatment or access to tocilizumab or some of the other GCA treatments if you don't have actual histopathology biopsy results, do you think?
Well, no, I don't think so. I think when we implement this new algorithm, it will be as if it was as good as a biopsy confirmation. So this hopefully should be accepted on equal footing as a biopsy results.
Stefan, I was going to
Based
ask.
on all our results.
Yeah, I was going to ask about access to PET imaging, because that for us in the UK is a real challenge.
Yeah, and of course that can definitely be a challenge. And we are privileged in our institution that we have access 3 days a week for a PET scanner, which is quite good, I would say. So this is, of course, also the case with the other imaging modalities I mentioned, MRI, PET-CT, and OCT. It depends very much on whether you have trained skilled personnel to perform the tests, and also just the ultrasound. It's just you need a real good training in order to do it probably. But I think in the right hands, I think it's going to be the future with these modalities.
And Stefan, we just discussed this in our system in the US, and I think one of the barriers I would see is cost, that black blood MRI or PET may be more expensive, certainly, than temporal artery biopsy. Was that a consideration at all or a concern in your system?
Yes, definitely. You always need to prioritize. These modalities are coming down in price also. But it is a concern, and it's always cost benefit in the different institutions. Well, how you want to prioritize, yeah, it's
I was just going to ask Prem, actually, because I loved your slide of the US versus Europe in terms of, how we're moving towards imaging. And certainly for second-hand treatment in the United Kingdom, we'll take an imaging confirmation to authorize the access to that treatment. But Prem, do you ever see in the US that they will go towards ultrasound, because they seem quite resistant?
There is a move toward it again, Susie. I think that as we are recognizing that it's the training of people that's really important to allow you to be confident in the results, that there is enthusiasm to go toward it, because it's not always easy to get the patient, even though it's cheap, to get the patient in to do the temporal artery biopsy. And there are, of course, disadvantages with that too, skip lesions and such. So yes, the short answer is yes, we are slowly, I think, working to adopt imaging and recognizing the advantages of doing so.
And Dr. Stephen, excellent talk. Just 2 quick questions. Any tips to improve the yield of the ultrasound? And second, do you also obtain a systemic imaging, like if the person had not gone a PET scan, would you do a imaging of the rest of the blood vessels of the body, thorax and abdomen in a patient with GCA?
For the first question, we are privileged to work together with the rheumatologists in our hospital that are very specially trained in ultrasound, and that are also very interested in it. So they also have a fast track clinic where they do the ultrasound all the time. So I don't really personally do it, or my fellows or the other ophthalmologists, they don't do it. But we're almost next door with these people doing the ultrasound. So we rely very much on their expertise. Of course, it will be most handy if we could do it ourselves, or if you could do it yourself. But I don't really have any good tips or tricks for that, because I rely so much on these collaborators. And so the second question was whether we image the rest of the body, including the abdomen in a case, and that depends very much on the case, because of course, if there are systemic symptoms coming from other organ systems, we do. But also, we don't do a full scan in each case, because both because of the cost of it, and also because of the potential risk of incidental findings and all this that comes up. But we do find a lot of just by doing the PET scan and the MRI scan, we do find a lot of incidental findings, and it's a whole discussion by itself whether it's a good thing or not. Yeah, that's interesting.
Thank you.
So I have a question, Stefan. Yeah. So how would you approach this patient of an occult GCA? Like you have so many modalities for imaging and tests. So like when would you consider this, that yes, the treatment has to be started for this patient?
So you need to be more specific in your definition of occult GCA, because as I mentioned, it's a very heterogeneous disease, so it can fool you a lot of times. So we have been surprised over the past years by such a large variety of phenotypes. So in classical cases, it's of course more easy, but in so-called occult cases, it's difficult. But what is an occult case? So it depends very much on what is the most prevalent. Sometimes you have like a clear temporal involvement and jaw claudication and a clear cranial phenotype. Then we will lean more towards doing an ultrasound of the temporal arteries, or perhaps also supplementing with a biopsy of the temporal arteries. But sometimes you have more vague symptoms with fever, some headache, and elevated biochemistry, and then perhaps it would be more relevant to do a PET scan. But as I mentioned, our diagnostic algorithm is not fully bulletproof and implemented yet. So I have to get back on that one.
Could I please request you all if we could move on to the next speaker due to lack of time? That's been a wonderful discussion, but maybe in the end we could take some more questions again, if that's okay. So we have Dr. Susan with us. She's affiliated to the Queen Elizabeth Hospital in Birmingham, and her topic is GLP-1 receptor agonists in idiopathic intracranial hypertension. Over to you, Dr. Molan. Please share your screen. Thank you.
Thank you so much. Can you see my screen at the moment?
Yeah, yes, perfect.
Fantastic. So really what we're about in the symposium is what's new for 2024. And although some of this work has been many years in coming, I really want to present to you GLP-1 receptor agonists in the use of people living with idiopathic intracranial hypertension. These are my disclosures, and I will discuss off-label use of medicines in this presentation. So we're all aware that idiopathic intracranial hypertension has diagnostic criteria. Raised intracranial pressure results in papilledema, and for the majority of people, debilitating headaches. IIH is a unique systemic metabolic disease, and we're finding things over and above what is conferred by obesity alone. And although obesity is a risk factor, the major risk factor for IIH, some of the things that we're finding out about the disease now is leading to increased cardiovascular risk, impaired fertility, gestational diabetes, and preeclampsia. There are a number of comorbid associations of IIH, polycystic ovarian syndrome, obstructive sleep apnea, and there is a significant mental health burden in our patients. And really the role of the ophthalmologist is to safeguard the vision. But as we know, we need to treat the underlying condition or signpost that patient to get treatment of the underlying condition to really prevent this long-term cardiovascular morbidity that we find. And modest weight gain, we know, pushes patients into this disease. And we know that weight loss, but we're not quite certain how much weight loss, is a beneficial treatment strategy. And this can be really challenging to actually implement. We know that large amounts of weight loss, up to 24%, which was shown in a randomized controlled trial, will normalize ICP back down to below 25. But 24% of somebody's body weight is generally not achievable, and it's certainly not achievable through diet and lifestyle weight management programs. We know that weight gain is associated with relapses of the disease, and this is a real problem because when people choose a dietary intervention, it is likely over the course of their lifetime that they will yo-yo in terms of their body weight. We've done a systematic review and we looked at the different interventions that have been used in IIH over the years. And we know that really bariatric surgery is the only current sustainable weight management therapy. But GLP drugs, this is from Bloomberg, recently said they're coming, but in fact, we know they're here and it could change everything. And it certainly is changing things all over the globe in terms of how we manage not only type 2 diabetes, but now obesity. So what is GLP-1? Well, it's an amino acid, a long-acting peptide, and it's secreted by 3 different tissues within the human body, obviously within the distal intestine, the pancreas, but also the central nervous system. And what it does in response to food intake is it increases insulin synthesis and secretion, and it decreases blood glucose, liver glucose production, liver fat content, and it increases satiety. And these drugs are now on the market across the world. So GLP-1 receptor agonists, and this is just an example of one of them, semaglutide, and showing you the really outstanding results that they've had in their clinical trials between placebo and actually utilizing the medicine. Now, there's many different types of the medicine, and they are working towards an oral preparation. But these have really been life-changing for many people. The problem with GLP-1 receptor agonists is the minute that you use them, you have good weight loss. The minute you stop them, the majority of people gain weight rapidly up to nearly baseline. And this would be a real challenge for patients with IIH because you would get that yo-yo of reduction in weight, reduction in intracranial pressure, cessation of papilledema, and then relapse of the disease, which would further risk visual loss. So the manufacturers are aware that these drugs have many different effects, all far beyond what they originally thought. And really, it's the central nervous system here that we are going to sort of hone in on. We know that GLP-1 receptors modulate fluid homosecresis in the kidney, and we know that the kidney is really the reverse of the choroid plexus. So work that was done in Birmingham showed that GLP-1 receptors were found in the choroid plexus in rodents, and then we took this discovery work through to the human choroid plexus. We then took an animal model of raised intracranial pressure and treated them with Exendin 4, a GLP-1 receptor agonist. And the results here really show the fantastic reduction in intracranial pressure in the rodents. And this paved the way for our phase 2 study, which was a randomized controlled trial using exenatide. And these were patients with active idiopathic intracranial hypertension, randomized 1-to-1 to use exenatide versus placebo. The one thing that was really special about this trial was our patients had intracranial pressure monitors. And that meant we were really able to interrogate the intracranial pressure in a way that we've not been able to before, having beat by beat pressure readings and avoiding serial and multiple lumbar punctures, which can be very traumatic for patients. And we wanted to look at an early time point, 24 hours and at 12 weeks of dosing. There were obviously a number of different secondary endpoints we looked at. And the results were really outstanding. We were very impressed with the difference between the patients on exenatide versus placebo. And here you see at 2.5 hours, you've got an excellent reduction in brain pressure. And we've converted that from the millimeters of mercury to the equivalent of centimeters of CSF. And again, you see that at 24 hours and at dosing out to 12 weeks. And so this was a very positive signal for exenatide in reduction of intracranial pressure. There was a phase 3 commercial study, which unfortunately has closed, and this was due to real challenges of recruitment worldwide and trial setup. But there are academic studies ongoing now to really understand whether this medicine will be able to translate for idiopathic intracranial hypertension. So in summary, really, when we think about IIH and its biggest risk factor, which is weight gain, weight loss is really challenging, and most people need professional help deciding the route of weight loss. Relapse of weight maintenance risks the vision, and it risks the relapse of IIH. The problem with bariatric surgery is really the access across the world. It has very high upfront costs, but there are sustained health benefits, but it's not for everyone. The problem with GLP-1 receptor agonists is there's a high risk of relapse when stopped. And certainly within the UK, these treatments are only given for a year or 18 months, and that's all the patients are generally allowed for obesity. So we have a lower sort of honeymoon period at the present time where lots of our patients are going on these medicines. Further down the line, we're going to have to carefully think about how we manage these patients as they come off their GLP-1 receptor agonists. The other issue is accessing this treatment is challenging, particularly in the private sector. It's very expensive monthly cost. And again, and I'll show you in a second, the side effects of the GLP-1 receptor agonists. Bariatric surgery gets a little bit of a bad press worldwide. I think that's much more historic. I think there are many advantages of bariatric surgery in terms of what it does for systemic health and how it improves things, particularly for people living with IIH. There are many barriers to accessing it, including cultural barriers and stigma. The complications, as I said, have really improved over the years, but these very carefully need to be laid out with the patient in terms of whether this is a procedure for them, because it's not something that's easily reversed in terms of Roux-en-Y gastric bypass. Obviously, bands and sleeve can be easily reversed, but they don't give the benefits that, say, Roux-en-Y do in terms of modulation of GLP-1. The side effects of GLP-1 receptor agonists, there's been this big, huge press about how they're wonder drugs, but actually when you speak to patients, the majority of them have debilitating nausea and vomiting. And for the IIH cohort, significant mood changes and in some cases suicidal ideation. So again, it's this balance of the risks of taking the medicine versus the benefits. So I would say that exenatide has been shown in our phase 2 study to significantly reduce intracranial pressure. This is really exciting for IIH in terms of a novel medicine for treatment. It's not known whether other GLP-1s have that effect on intracranial pressure. There needs to be further work done here. And really, I think a trial of exenatide in, say, sight-threatening papilledema would really be of interest because of that early signal that we saw in the phase 2 trial. So I'll stop there and see if we've got any questions from the panel.
Thank you so much, Susie. Can I ask you the first question? Outside of your phase 2 trial, do you think there's any other evidence that these GLP-1 receptor agonists would be good for, say, fulminant IIH?
Yeah, I think that's a really helpful question, because obviously we saw this signal just in this phase 2. In our weight trial, actually, we did lumbar punctures at 2 weeks following bariatric surgery in a large proportion of our bariatric surgery weight trial. And at 2 weeks, actually, their intracranial pressure was reduced as it was at 12 months. And understanding that mechanism is quite difficult, but we performed meal stimulation on our patients, and we show that actually it's GLP-1 that's driving that reduction in ICP. So I think that evidence, along with the phase 2 trial, shows that it would be, exciting if we were able to use something like exenatide for our patients and avoid shunts, optic nerve sheath fenestration, stenting. So I think we'd be very keen to take that forward.
That's really exciting. Thank you so much.
Don't have any other questions, we could move on to the next speaker. Thank you so much, Dr. Susan. That was a wonderful talk. Now we have with us Dr. Darshi Ramanathan, who's joining us from the University of Sydney, Australia. She'll be talking to us about new management paradigms for myelin oligodendrocyte glycoprotein, that is MOG-associated optic neuritis. Could I please just remind the speakers to stick to the time limit of 10 minutes, and we have about 4-5 minutes for discussion after that. We also have some time reserved at the end to have a panel discussion together. Thank you.
No worries. Can you see my slides and can you hear me all right?
Yes.
Wonderful.
Yes.
All
Thank you
good.
so much for the invitation to talk about new management paradigms in MOG antibody-associated neuritis. So MOG, or myelin oligodendrocyte glycoprotein, is a minor component of central nervous system myelin, and it's generally expressed on the outermost layer of the myelin sheath and oligodendrocytes. And over the years, there have been an evolution of the type of assays that are most sensitive and specific in order to detect the presence of MOG immunoglobulin G in human serum. And we now have established cell-based assays which can be picking up or detecting these MOG IgG in patient sera, either quantitatively using flow cytometry or qualitatively using microscopy. And what this has identified is that MOG antibody-associated disease represents a very distinct group of demyelination. It's distinct from aquaporin-4 antibody-positive neuromyelitis optica spectrum disorder, or NMOSD. It's distinct from multiple sclerosis. The clinical phenotype that it's characterized is in the major part actually optic neuritis, and as you can see in that first graph, it's the most common initial presentation both in adults and only second to acute disseminated encephalomyelitis in children, and certainly the most common relapsing phenotype in adults and children. And I'll be talking very briefly about typical characterization of MOG antibody-associated neuritis, but I just wanted to highlight that it's also associated with ADEM in children, short and longitudinally extensive transverse myelitis in children and adults, and infratentorial brain involvement, cortical encephalitis, seizures, and leptomeningeal involvement as well, however, to a much lower degree. Optic neuritis, on the other hand, is one of the most common phenotypes. The optic neuritis with MOG antibody-associated disease is longitudinally extensive, often bilateral at initial presentation, and in that way can look similar to aquaporin-4 antibody-positive optic neuritis, but quite distinct from the more focal, often unilateral involvement of the optic nerve in multiple sclerosis. However, what's characteristic in MOGAD is a really significant propensity towards anterior visual pathway involvement. So either optic nerve head swelling on fundoscopy or radiological optic disc cupping, as you can see here with the arrows, radiologically. And this is very characteristic of MOG antibody-associated disease and extremely rare in aquaporin-4 antibody-associated disease. This is moderate to severe disc swelling, can be associated with hemorrhages, and it's not like the mild disc swelling you might see in some of the other etiologies. In contrast, that posterior visual pathway that you can see in neuromyelitis optica spectrum disorder with aquaporin-4 antibodies, where chiasmal and optic tract involvement is present, is very unusual in MOG antibody-associated optic neuritis. And in the rare cases it happens, it's usually associated with contiguous longitudinal involvement of the optic nerve rather than that isolated chiasmal involvement you can see with the aquaporin-4 antibodies. The other very characteristic hallmark is the presence of optic nerve sheath enhancement. And we can see some features of the disc swelling, the perineuritis, and the longitudinally extensive involvement in MOG antibody-associated disease that is distinct from with the absence of posterior pathway involvement that renders it quite unique. Now, before going on to treatment, I think the important point is why we treat these patients and how do they do in the long term. And MOG antibody-associated disease essentially has always been compared favorably compared to aquaporin-4 antibody-positive NMOSD. And I'd like to caution that a lot of these improved outcomes in cohort studies internationally come when you compare the Expanded Disability Status Scale, or EDSS, which is classically derived from the literature in multiple sclerosis and is very locomotor dependent. So it's less sensitive as an outcome measure when you look at visual function, which patients can be legally blind and not score very much on their EDSS if they don't have cord involvement, for example. In a study we did looking at relapsing patients, we showed that 25% of patients still had residual visual impairment affecting their activities of daily living, even though they didn't score very much on an EDSS. And what we can see here is that at initial presentation with MOG antibody-associated disease, the optic neuritis when you look at the visual functional system score or looking at visual acuity components of the EDSS, similar to those with aquaporin 4 antibody positive, they have very severe impairment at onset, but you can also see that they continue with the MOG antibody positive patients to be impaired at follow-up in some cases, although many of them do recover favorably. And what you can see is also swelling acutely of the retinal nerve fiber layer, much more than you would expect to see with MS or aquaporin 4 antibody positive optic neuritis. But often, despite preserved visual acuity, these patients might have retinal nerve fiber layer atrophy. Now, when we think about the treatment of MOG antibody-associated optic neuritis, it is a very steroid-sensitive, almost exquisitely steroid-sensitive condition, but it's also quite steroid-dependent. And what we know and what other groups have confirmed has also been that when you treat them initially with pulse steroids or with high-dose oral prednisone, they do quite well. Then when you try to wean the prednisone, when you come down of adult equivalent doses of less than about 10 to 15 milligrams a day, pediatric equivalent doses of 0.15 to about 0.2 milligrams per day, there's a little spurt of relapses. And then when you cease the prednisone, within the first 2 to 3 months, there's a big rise in relapse rates. So when you look at what does maintenance treatment look like in chronically relapsing patients, and here we've combined, outcomes from different studies looking at this issue and looking at the annualized relapse rate, which is often used in demyelination before treatment compared to on treatment. These patients tend to respond to immunosuppression similar to what you might consider in NMOSD. So rituximab, mycophenolate, intravenous immunoglobulin, prednisone. What they don't respond to is MS immunomodulatory therapies like glutacopaxone, natalizumab, interferons, alemtuzumab, which tend to have been shown in small studies to increase the relapse rate. So early and accurate diagnosis is very critical and has therapeutic and prognostic implications. Now, when you have a chronically relapsing patient, what can you use in these patients? And rituximab is a bit of a controversial, and the jury is still out on this. So you have systematic reviews and meta-analyses showing that it definitely reduces the annualized relapse rate in patients, but there's also important studies saying that despite B-cell depletion, a third of MOGAD patients tend to relapse while on rituximab compared to a much smaller proportion of aquaporin 4 antibody positive patients. So they seem to be a little bit less sensitive to B-cell depletion than the NMOSD patients. Another treatment that's been used in relapsing disease that is shown to be quite successful has been intravenous immunoglobulin as maintenance therapy. And what's important to note here is that using it at a high dose, so 1 gram per kilogram at a frequency of a month, significantly reduces relapse rates. But if you try to reduce the dosing or extend the treatment intervals, patients tend to relapse. So it works well, but it's an expensive resource and it's not disease modifying. So when you stop the treatment, patients are back at a baseline risk of relapse. Interestingly, in the horizon and actively recruiting are 2 international phase 3 RCTs looking at different monoclonal antibodies. One is to an IL-6 receptor antibody, so this is satralizumab versus placebo, and another one is rozanolixizumab versus placebo, which is an FcRn targeting mAb. So this is still actively recruiting, so it'll be interesting to see what these results show. Now, MOGAD was initially touted as a monophasic disorder with a good outcome. However, numerous international studies have demonstrated, and our group has collated information from about 4,000 patients looking at international cohorts and conglomerating these results and demonstrated that this relapse rate increases the longer you have follow-up. So while you have a 50% or less than 50% rate in children and adults, as you increase the follow-up period, more patients end up relapsing. Does this mean that every patient at onset should go on to maintenance treatment? And once again, the jury's out on this because you don't necessarily want to immunosuppress for the long term a child or a young adult who might have 30% chance that they were not going to have a relapse. The other side of the coin is that MOGAD is a fairly easily recoverable disease in most cases, not all, but most. And giving them high-dose steroids early on can often result in rapid recovery. And this is quite contrary to what we express with NMOSD, where we really don't want to risk a patient having a relapse. So it's still not clear whether or not a patient diagnosed with MOGAD should be having ongoing immunosuppression. Now, there's a very interesting study by the Oxford group that demonstrated that patients who have a very early relapse, which is classified as being within the first 3 months after a disease onset, or had an early relapse, which is classified as being within the first 12 months after disease onset, had a higher rate of becoming chronically relapsing. And that brings to mind the question, is what we do to them at disease onset, does that have, above and beyond the treatment of that episode, does that have a more long-term impact on the natural history of the disease? And this is an area we've been actively studying in our national group. And we've been looking at multiple doses of treatments at onset, from high dose down to no treatment, and identify that actually patients don't necessarily need to be on very, very high doses. When you come down to about 12.5, you can still see a big separation, 0.16 milligrams per kilograms in children, 12.5 in adults. And this is maintained when patients have that kind of threshold treatment for about 3 months, whereas less than 3 months, patients tend to relapse much more quickly. So this will be interesting to see. Now, the final point I'd like to make is treatment is very much linked to, are there going to be prognosticators for relapsing disease or disease severity? And while they're clinical prognosticators like optic neuritis associated with a higher risk of relapse as children, persisting seropositivity, there are not many serological biomarkers. Some work that we've done and other groups are also identifying at the moment is that the epitope of the MOG-IgG, the epitope profile might be allowing some measure of prognostication. So patients whose MOG-IgG does not recognize the proline 42 epitope seem to be much more strongly correlated with the relapsing disease course. And this is present at onset and doesn't seem to change through the history of treatment of a patient. So it's potentially something that could give us a bit of a clue about those patients who are more likely to be relapsing. So in conclusion, MOGAD frequently manifests as optic neuritis. It's a relapsing disease that's steroid responsive and dependent, and maintenance immunosuppression may be required, but the ideal maintenance immunosuppression is not yet clear. These patients do have the potential to develop long-term visual impairment, and how we treat people at the disease onset and how we prognosticate patients is very important. I'd like to thank my funders, my research team, and our collaborators in our national study group, a very important member of whom is also Claire Fraser. Thank you.
Thank you, Dr. Darshi. That was wonderful. Any questions from the panel?
So can I just confirm with you, Darshi, thank you for that fabulous talk. You would propose keeping people on 12.5 milligrams for like 3 to 3 months or so as a minimum before trying to then reduce them below that based on that data?
Yeah, so I didn't show all of the background, but we basically looked at very, from 50 milligrams a day to no steroids at decrements of 2.5 milligrams, and looking at all the patients in our cohort and trying to identify when that separation started to melt away. And you kind of obviously see it at high doses, but it's still pretty significant down to about 12.5. And after about 10, it starts to really harmonized and ends up being not much different. So I guess our aim is, what is the minimum dose of steroids and the minimum duration required to maintain disease remission? Because none of us want to treat our patients with prednisone for longer than needed, and particularly the pediatric population as well. There's a lot of implications. So I think what we've landed at close to at the moment is 12.5 milligrams per day in adults, 0.16 milligrams per kilogram in children for about 3 months. And then you can kind of go down, and it seems that the long-term implications looking out 18 months after onset is these patients don't seem to be having the relapses that those who have those quick pulses, the quick 2-week tapers, and then almost invariably relapse very quickly.
Really interesting. Thank you so much.
Thank you.
Yeah, it brings up an interesting correlate, right, with what we speculated about from the ONTT about how incomplete treatment at onset might predispose people to relapses. And that's a very interesting observation.
Absolutely. And the other, I suppose, the other ONTT was has been such an important trial in the field of optic neuritis. And it was very interesting when looking at patients that they had about 177 sera available from those 450 plus patients, and went back and had a look at them. And interestingly, only a very small number
That's right.
had actual
Only
MOG
three, I think, right.
Yeah,
Yes,
three,
exactly.
yeah. But I think when you look at the exclusion criteria, bilaterality and so on, so I think they got rid of a lot of patients at the onset, but it's very interesting. Thank you.
Thank you so much. Before we move on to the next speaker, we have with us Dr. Murlidhar, who's just joined in on our panel from Eye Foundation, Coimbatore. So are you here? Okay, and
yeah, I'm online. Yeah.
Yes. We move on to Dr. Virendra Sachdev, who will be talking to us about emerging trends in the management of optic neuritis. So, as a consultant at the GMR campus at Visakhapatnam of LV Prasad Eye Institute. So, please start your presentation.
Yeah, thank you. And I hope my slides are visible.
Yes.
Okay, thank you. So I think we take over from the previous talk, and Dr. Darshini highlighted many important things about emerging optic neuritis. If we look at the current emerging trends in the management of...
Sorry to interrupt, Doctor.
Yeah.
Can you make it the slide share, please? Full slide.
Okay, 1 second.
You stopped it.
Yeah, 1 second. Is it slideshow now?
Yes, sir.
Okay, great. So coming to current understanding of optic neuritis, when we talk of optic neuritis, we believe that we are talking mainly about the demyelinating form of optic neuritis. Though para-infectious, post-infectious, and post-vaccination optic neuritis do occur commonly, especially in our part of the world. But among the demyelinating optic neuritis, it could be a clinically isolated syndrome, or it could be demyelination occurring in the setting of a systemic neuroinflammatory disorder, top being MS, edema, neuromyelitis optica, and MOG-associated demyelinating disorders. So currently, we all understand that that optic neuritis is not the final diagnosis, but it's a syndromic presentation in a patient presenting with vision loss, usually with pain on eye movements and dyschromatopsia. We need to find the underlying etiology and subclassify as optic neuritis in the setting of various demyelinating disorders, and even the ones which are getting discovered and we are learning more about them, such as GFAP associated optic neuritis. So in the current understanding, what is the literature from the Western world that tells about the final etiology? So in this recently published study, they prospectively evaluated patients with optic neuritis, and they found that MS was the most common, and in about 57% of patients, followed by idiopathic in about 29%, and MOG and aquaporin positive NMOSD accounted for about 9% of the total. That is 1 out of 11 cases of optic neuritis, which is fortunate because they are associated with recurrences, as was discussed previously, and may have suboptimal visual outcomes, especially NMOSD. Similarly, the pediatric optic neuritis study showed that while half of the patients had isolated optic neuritis as the most common etiology, MOG accounted for about 18% of cases, followed by edema. MS and NMO were relatively infrequent. They also showed that the associated immunological diagnosis was associated with a worse visual acuity at presentation. However, that was not the case with the final visual outcome. So why it is important for us to distinguish? Because each of these diseases have different chances of recovery, relapse rates, and recurrences. They can also have progressive neurological disability and permanent vision and neurological deficiency, especially in patients with NMOSD. So what about the Indian data? So in this study published last year by Shankar Netralia group, they evaluated 203 patients, adults and pediatric patients with diagnosed optic neuritis who had undergone neuroimaging and serological testing. What was interesting was to note was that the most frequent etiology was double seronegative optic neuritis found in about 56% of patients, followed by MOG in about nearly 1/3, NMO in about 10%, and MS was only 6%. So it's quite a contrasting result from India. What was also noted was that female preponderance was noted only in MS and NMO, but not in MOG-associated optic neuritis. They also showed that the predictors of worse outcomes were bilateral sequential involvement, associated disc pallor, retrobulbar optic neuritis, and NMO seropositivity. So a little bit more about double seronegative optic neuritis. These are the two major studies which I could found about the reporting about double seronegative optic neuritis, one from the group in Japan and the one from India published last year. We looked at our patients at LVPI with patients having non-MS, NMO, MOG negative optic neuritis. We found 98 eyes of 67 patients. And if we summarize the chief findings from majority of these studies, we see that majority of these patients are in the 3rd or 4th decade. The female preponderance is not seen so much as compared to MS and NMO. The bilateral simultaneous involvement could be seen in about half of them, and sequential involvement could occur in a large number of patients. And in the Japanese experience, it was seen in about one third of the patients. A large number of patients do not have papillitis in our experience. However, in about 46% of patients in the Japanese group, they observed papillitis at presentation. Pain on eye movements is similar to other kinds of optic neuritis, and CNS symptoms were not seen so often in the study from SN and neither in our group. But in the Japanese group, they reported the distribution of brain lesions but did not tell about the symptoms. What is interesting is that while the presenting visual acuity can be pretty low, majority of the patients in all the studies did have good outcome. If we look at the distribution of the optic neuritis lesions, in our experience, we found that in about 68% of patients, there were brain and orbital lesions. And we found that anterior orbital lesion was found only in about 1/3. Long segment was noted in about 1/4. And posterior optic nerve involvement was noted in about 1/3. This is similar to what is reported in the other literature from the prior studies. As I showed before, we expect a good outcome in terms of visual acuity as well as visual field improvement at the final follow-up. And most common field effect at final follow-up was either a central scotoma followed or a normal fields. We noted recurrence in only about 3% of patients, and the literature suggests that about 12% of patients might have recurrences. So in summary, double seronegative optic neuritis might be most common form in India and Asians. They do have a similar age at presentation as compared to the other neuroinflammatory syndromes. However, there is no gender predilection. Pain on eye movements is noted in about 1/3. Papillitis is not very common. They might have retrobulbar optic neuritis or optic disc pallor. There can be long and posterior segment involvement on MRI. They have a profound visual dysfunction, but good response to treatment. As of now, the limited studies suggest a low recurrence rate. So as regards management, we all know that acute phase is by the IV pulse methylprednisolone therapy, which most of the people give for 5 days, and chronic phase is majority of the patients after a final diagnosis are started on immunomodulator drugs. So as was discussed in the previous presentation, the MS and NMO majority of the patients are preferred to be started on the immunomodulators, whereas in patients with MOG, about 30% only have recurrences. So it is definitely indicated for recurrent cases, but not for everyone as of now. we do have a vast majority of options as of now, and plasmapheresis and IVIG can be utilized in the acute phase. Just to highlight about that, this is a patient who had been diagnosed as bilateral optic neuritis, presented with very poor vision in both eyes and marked disc swelling. We can see that long segment optic nerve involvement along with posterior segment optic nerve involvement in both eyes. Even after 3 doses of methylprednisolone therapy, the patient did not show any improvement. So 2 weeks later, when the patient presented to us, the vision was no light perception in the right eye and hand motion in the left eye. The disc edema was resolving. We saw that the RNFL was still thickened as well as MGCL was quite okay. So we tried other options. We sent for NMR MOG, which were negative. We did repeat imaging, which showed status quo, and we did a repeat treatment with IVMP followed by plasmapheresis, and rituximab was added to the regimen. And there was great improvement. At 2 weeks follow-up, you can see improvement in the visual acuity to 20/80 and 20/20 in right and left eye respectively. Formal fields were possible with inferior arcuate-like field effects, and we can see that there is significant improvement even 2 more weeks later. So this showed a good outcome in patients with poor recovery, optic neuritis, if they are treated with plasmapheresis. So there is enough literature telling about this, and this is the largest study which is published last year, telling about the experience of PLEX in patients with acute optic neuritis. They had seen 378 patients and 479 optic neuritis attacks. And it was noted that about 43% of the patients had 20/20 visual acuity at final follow-up, and only about 20% of patients did tend to have a visual outcome worse than 2200. What is important was that PLEX was well tolerated. It was also studied in the study telling about what is the benefit given in various forms of optic neuritis, and maximum benefit was noted in MOG-associated optic neuritis. However, MOG might have a good outcome otherwise also. What was interesting to note was that aquaporin-associated optic neuritis, about 1/3 of the patients tended to have poor recovery still. So it remains to be seen how to manage those. What is also interesting to note is that the PLEX works best if it is started within first week, and the chances of recovery reduce once it is later than the first week. So among the factors associated with poor outcomes, it is the higher age at presentation as well as weeks to plasma exchange. They also showed that in patients who had recurrent optic neuritis, also about 50% of patients recovered to baseline visual acuity and another 20% improved 3 lines. So in summary, PLEX is very important in the acute phase management in patients with NMOSD, and even might be in MOG with poor recovery. Might be useful in double seronegative patients, but MS is less likely to have benefit. Can also be tried in severe and recurrent optic neuritis, and it's shown to be effective and safe, but it's important to do it early. We did see in our experience what happens to these patients if we are not able to afford PLEX and if they have been treated only with oral steroids or immunosuppressive agents. So in interest of time, I'll just go to the result slide, and we did see that even with oral steroids, they tended to show good recovery over a period of time. However, at this point of time, we did not have enough patients to see according to the final etiology. And I think I'll just go last to this, what we have observed about factors predictive of recurrence in MOG optic neuritis. And coming just to the results, this study was already highlighted by Dr. Darshini. What we observed that among 48 patients with recurrent 48 patients of MOG positive optic neuritis, 27 had recurrences and 21 did not have recurrences. We found that there was no significant difference as regards their age, gender, but significant results were found to be different if they had the recurrence rate was higher if they had unilateral presentation, pain on eye movements, and if immunosuppression was not started at the first episode. we initially observed that presence of brain MRI lesions was more frequent in patients with non-recurrent optic neuritis, but majority of these patients had been started on immunosuppression, so possibly that was a bias. So with this, I would like to conclude by saying that at this point of time, we need to categorize and recognize the final etiology in these patients. We need to have aggressive, acute, and chronic treatment as per the etiology. And as regards occurrence in emerging optic neuritis, it's noted in about 1/3 of patients. We observe that it could be more common in patients with pain on eye movements, patients who have unilateral episode and not given immunosuppression, and at least a prolonged taper of oral steroids can be given. Thank you very much for a patient hearing.
Thank you, sir. So I wanted to ask a question. If you're suspecting a patient would need Plex in case of optic neuritis, would we wait for a serum analysis for the MOG or NMO, or on clinical suspicion we should go ahead with Plex?
I think at this point of time, we are not still able to get the reports within 5 days or
Yes, sir.
1 week, but as the literature tells that the response is best within the 5 days or 1 week. So if you're not having good recovery, possibly it might be good to counsel the patient and recommend plasmapheresis early, especially if there was no recovery at end of 5 cycles of methylprednisolone.
Right. Okay.
Dr. Prem might like to add something on this. Other panelists.
So I think that's very reasonable. In fact, in our institution, we have a low threshold for instituting Plex, even simultaneously with the corticosteroids. We also have to wait a few days to get the results back in a newly diagnosed patient. So I would not hesitate to go to Plex, given the data that are out there.
Thank you.
Can I ask a question?
Yes.
Yeah, I have a question for Dr. Virender and the other panel members regarding testing for MOG and the NMO. Do we do it in all cases, or like if the MRI is suggestive of MS, we don't do it only if the MRI is normal or it shows features not suggestive of MS, we do it. Can we stratify it like that? I mean, if it is showing MS, we don't do it. If it is not showing features of MS, or if it is entirely normal, then we go ahead and test for NMO MOG. Is that a satisfactory protocol to be followed?
Yeah, I think that is a very satisfactory suggestion, especially if we look at the socioeconomic status of our patients and they are not insured. But I don't know what Dr. Prem and other panelists have to say about what do they obtain in patients with MS likely.
Dr. Ramanathan, any thoughts?
I could make a comment on that. I think it's really important to understand the assay methodology and the sensitivity and the specificity of the assay. Live cell-based assays, for example, are highly specific and sensitive. Fixed cell-based assays, which are what is generally globally available in certain settings, have a much lower sensitivity and specificity. So testing patients who have a low pretest probability will stretch that sensitivity and specificity even more. And I think if you've got a patient with brain MRI changes consistent with multiple sclerosis, they have multiple sclerosis, and I don't think we don't recommend testing for MOG antibodies and aquaporin 4 antibodies. I was one of the members of the diagnostic criteria that was proposed for MOGAD in 2023, and it was kind of strongly recommended that we avoid testing in adults, particularly those who have a clear presentation of multiple sclerosis on radiology. The difference is you would probably test for all children under the age of 11 with a demyelinating presentation, because in that age group, 50% of those patients are going to have MOG rather than anything else. So the recommendation at the moment is testing all children under the age of 11 with demyelination, and over the age of 11 or 12, those in whom you think it's a possible diagnosis.
And do you have a comment on whether you should test serum, CSF, or both?
Absolutely. So serum, without fail, that is the most appropriate biosample to use. Research assays looking at serum and CSF basically show that 60% of patients with paired samples will be positive in the CSF. So if you only send a CSF sample, you will miss your diagnosis in 40% of patients. The flip side of that is if you only send, if you have a serum negative and a CSF positive patient, that opens up another can of worms. So they're intrathecally restricted MOG. And there are certainly some patients described in that setting who have a clinical phenotype highly consistent with MOGAD and probably have MOGAD, but there are also patients in that group that have spinal cord infarction, tumors, Leber's and all kinds of different things. So I think always test the serum. If you're interested, you can test both paired, but be wary of the CSF intrathecally restricted MOG IgG.
Okay,
Great,
thank you so much for that discussion. We'll move on to our final speaker for today. We have Dr. S. Mahesh Kumar with us, who heads the Neuroophthalmology Services at Arvind Eye Hospital, Madurai. Dr. Mahesh will be speaking to us about conquering traumatic optic neuropathy. Over to you, sir. Please share your screen.
So, is my screen visible, Dr. Madhavi?
Yes, sir. Just could you increase the volume a little bit? We can't hear you really well.
Okay. Okay. So, good evening. And am I audible, Dr. Madhavi, now?
Yes, sir. Perfect. Thank you.
Okay. Thank you. First, I would like to thank the organizers, Rashman, AOS, and Dr. Madhavi for having invited me here. The topic given to me is what I'm doing new, and I thought I would take something what we see more commonly in our setting, which is traumatic optic neuropathy. And so there are various challenges in the management of traumatic optic neuropathies. So far, there has been no evidence-based guideline for the evaluation and the proper therapeutic agents for this condition. And there has been no large natural history studies for this condition, no randomized controlled trials. Both surgical decompressions as well as corticosteroids have been proposed so far. And observation also has been proposed so far. None of the studies conclusively saying any conclusive results on the proper management of this condition. So when we mean traumatic optic neuropathy, we mean about two types of traumatic optic neuropathies. One is an anterior indirect injury where the injury is predominantly in the intraocular optic nerve here, and where it contains the vessels of the central retinal artery. And any injury at this point, wherever it's anterior to the entry of the central retinal artery in the optic nerve, leads to instantaneous vision loss, and so it leads to a total central retinal arterial occlusion or probably a total avulsion of the optic nerve. And in these instances, we don't have any treatment per se, and so its vision is most likely irrevocably lost. But what we can intervene in the majority of the conditions, which are posterior indirect traumatic optic neuropathies, which occur at the posterior part of the optic nerve, which are typically due to injuries in the lateral third of the eyebrow region in the forehead, and where the injuries are transmitted along the bony wall to the optic canal here, such as this one, crushing the optic nerve inside the optic canal and typically leading to vision loss. So in our setting, in the last 3 years, we have had this many number of traumatic optic neuropathy cases. I'm sure any institute in India will see similar number of cases, given the large number of two-wheeler presence in our country, and with the not so severely enforced rule of wearing a helmet. So we do see lots and lots number of traumatic optic neuropathy with a typical fall from two-wheelers. The common histories we hear are not a rash riding or a race riding, but a small normal riding, a dog coming in front of the bike or a speed breakers. A normal riding with a fall typically causes this. And in 2021, we had 130 cases out of this many number of new cases in neuroophthalmology. And 2022, it's a similar number of cases. And 2023, we have had around 148 cases out of about 10,000 cases of new patients of traumatic optic neuropathy. So in this setting, we see this many number of these typical presentations with a subconjunctival hemorrhage, a typical injury to the forehead, and a relative afferent pupillary defect and a normal fundus to begin with. So the pathogenesis postulated are the primary injury, which occurs at the time of at the moment of injury, causing a mechanical shearing of the optic nerve, leading to retinal ganglion cell death. Other causes being contusion necrosis, causing ischemia. So when this is severe enough, the patient's present with no light perception and probably no amount of treatment and no form of treatment is going to help the patient. Fortunately, in many of these conditions, this sort of primary injury is only partial. And so we have enough number of optic neurons left for us to salvage whatever vision is left. But more severe is the secondary injury, which occurs after the primary injury has occurred. And it is at this stage which we would like to target, the secondary injury stage, where there is vasospasm and swelling of the optic nerve within the canal and accumulation of free radicals within the optic nerve, causing further destruction of the optic nerve. And it is at this stage where we can meaningfully salvage the optic nerve. And it is at this stage we want to intervene. So typically steroids were used, and it is said that they reduce the amount of traumatic edema and limit the severity of the contusion necrosis of the nerve. And steroids may also reduce the degree of vasospasm that accompany the trauma. And this is largely based on the NASIS trial on the spinal cord treatments, where they gave large bolus of IV methylprednisolones with partial recovery in the spinal cord injury cases. So based on this, many studies were proposed, and the known one being the International Optic Nerve Trauma Study, where it was stopped in between due to poor recruitment, and they did not find any significant difference in the patients treated with steroids or surgery with steroids or observation. So it was not, study was not completed, and it could not yield meaningful results. And then came the CRASH study, which said that there is a high mortality in steroids where there is a significant head trauma. So this also limited the use of steroids. And surgery was proposed to decompress the optic nerve sheath hematoma by medial orbitotomy and neurosurgical decompression. And again, there is no meaningful recovery as compared to no treatment. So it is at this context where erythropoietin as a human recombinant erythropoietin as a mode of modality came into being. And it was proposed that it counteracts the secondary mechanism of optic nerve damage at the secondary level after the primary injury, including its antioxidant and anti-inflammatory properties, reducing the compartment syndrome, and simultaneously having decreased side effects as compared to IV steroids. It was also proposed that it has got anti-apoptotic activity of the retinal ganglion cells, and this neuroprotective effect helps to maintain the survival and possibly regain function following axonal damage. So on this basis, some studies were done. This is an Iranian group where they did a pilot study on erythropoietin versus IV steroids, and followed up with a regular treatment of traumatic optic neuropathy with IV erythropoietin and IV steroids. So they found no significant difference in the outcome, meaning equally good results in erythropoietin as compared to steroids. And in this context, we thought in our setting with a large number of traumatic optic neuropathy cases, we will do a study. And initially we started with a pilot study, where we recruited only about 18 cases, and it was published last year in the Indian Journal of Ophthalmology. And it concluded that erythropoietin showed equally good results with lesser or no side effects when compared to IV steroids. Now, these are the summary of those results. It was a pilot study from August 2019 to 20, and totally we recruited about 6 patients in each group. And group 1 was patients recruited prospectively, receiving recombinant human erythropoietin. And group 2-3 were recruited retrospectively. So since it was a pilot study, we wanted to know how it worked. And one group retrospectively had received methylprednisolone, who had presented to us less than 2 weeks after presentation, after they might have got treatment elsewhere for other injuries, and they came to us later. And another group got just multivitamins, who had presented to us after 2 weeks, having received no other treatment. And what we had found in that pilot study was there was no significant difference in the mean visual outcome between the erythropoietin group and the steroids group. And vitamins, just multivitamins showed a modest improvement with very minimal side effects in the erythropoietin group. So there is no significant difference. So both erythropoietin and steroids were effective in the management of traumatic optic neuropathy. So in this context, now we have initiated a prospective study comparing. We have just started that study and recruited just about 3 cases. We plan to recruit about 30 cases, 10 cases in each category, and hopefully find out a definitive answer to this. One group we are treating with medical treatment with high dose methylprednisolone 1 gram daily for 3 days, and the other group we have randomized it prospectively for a recombinant human erythropoietin injection, and the third group we are giving both methylprednisolone and erythropoietin combined, separated at 2-hour interval, and we would like to see the results in about a year's time. So erythropoietin we give intravenously about 20,000 international units for 3 days, every day for 3 consecutive days, mixed in 100 ml normal saline slowly over a period of 1 hour. Our recruitment is interval of 2 weeks or less, and adult patients having indirect traumatic optic neuropathy. We do all the baseline essential assessments, and they're randomized to 2 groups, and we will be following up these patients for about 3 months. Significant exclusion criteria we have defined are hypertension, polycythemia, and renal clearance more than 3 creatinine more than 3 milligram per deciliter because of volume overload we are producing due to erythropoietin, and hyperkalemia is also something we would like to avoid. So please check the potassium levels also, and all these patients get a clearance from our internist before being started on this erythropoietin. So with this treatment trial, we hope to find out some answer to this vexing problem of traumatic optic neuropathy, which we see every day, and hope to prevent this condition from becoming this condition. Thank you very much for your kind listening.
Thank you so much, sir. I would like to invite any questions from the panel.
Yeah, I have one question here. So many times we see that there are few patients who maybe within the first 5 days, 6 days when they present to us don't recover even when you give them the best of treatment. And there are others who would come maybe after 2 weeks and you give them some kind of steroids and they start to recover.
Yes.
So how can we differentiate who would recover, or how to counsel these patients? And secondly, when is you can say, till what duration can we give them a trial of IV methylprednisolone when they present to us?
So in our setting, we typically offer them steroid treatments up to 2 weeks. 1 week will be ideal, but up to 2 weeks we offer them, giving them clear broader visual prognosis. And as you have said, many patients who had no light perception at time of presentation elsewhere, and having taken no treatment at all after having come to us after 5 days or so, we have seen them improving to about 5/60 or 6/60. We have seen that, and many patients who are presented to us immediately, and whom we have given immediate steroids within 6 hours also with no light perception, we have seen no improvement. So as you say, it's really hard to say which patient will improve, and every patient we give them a guarded visual prognosis, but we give a time limit of about 2 weeks. We offer them till 2 weeks some form of treatment in this condition.
Sir, I had one question. How easily is erythropoietin available if we want to give it to our patients?
Yeah, it is quite available. Oakart company is making it. There are several other companies. It's easily available. It's because it's being given regularly by the nephrologists for anemia and other similar conditions. So for us, it's a new drug, but for the physicians, they regularly use it. So I think it's easily available throughout India. Of course, they use it at a much smaller dose, maybe 1,000, 2,000 international units. But what our studies have found out is, our ophthalmology studies have found out is, we need to give it at a much higher dose than the normal, just like steroids. At a higher dose, like we give 20,000 units. So at least 10,000 to 20,000 units we need to give to have it some neuroprotective effect.
Thank you.
Can I ask a question?
Yes,
So Murli here.
yes,
So
Murli.
any experience with this optic nerve sheath decompression? I mean, in what cases would you attempt them, or would you not give them a try at all?
Yes. So we do work with an ENT surgeon, and whenever there is a patients have no light perception, with a clear fragment of the bony fragment, possibly potentially impinging on the optic nerve in the canal, we offer them, but telling them that removing this fragment by no means will guarantee a recovery of vision. So we do it very sparingly. We refer these patients very sparingly, and maybe 1 or 2 patients per year we would refer them to the ENT surgeon for decompression. And I think in the last 5 years, if we had referred around 10 patients, we might have seen around 1 or 2 patients recovering out of that procedure. So we don't really believe in that, but when patients really want something to be done, we give them that option.
Okay, thank you.
Any
Dr. Mahesh, taking further the question about predictors, do you observe that patients who have a flat VEP, completely extinguished pattern VEP, and just poorly reproducible flash VEP, do they have a worse chance of recovery?
Yes, possibly. VEP, which is really flat, and flash VEP also flat, they do have a poor prognosis. And but having said that, we don't. We don't use the VEP as a guideline to treat or not. We offer the treatment for every patient, and we don't do it really for all the patients on the visual evoked potentials. We just see the clinically the relative afferent pupillary defect and other things.
Thank you.
Are there any other questions pertaining to any other talks that we have today? We also have Dr. Honavar, who has just joined in talk. So are you there? Okay, I would like to please invite Dr. Subramaniam to please give in some closing remarks. We've had a wonderful time learning a lot of new things over the last 1 hour from all over the world. Sir, any comments?
I think that the talks today have really demonstrated that there is interesting research going on and real advances that are going to influence our patient outcomes. We talked about the changes in the diagnosis of GCA and how non-invasive testing is probably going to replace temporal artery biopsy in our evaluation of those patients, how we may have better medical options for treating our patients with IIH as well, and potentially avoiding surgical interventions that have their own issues there as well. So I think these medical advances are really fascinating. Optic neuritis, our understanding of it continues to evolve, and particularly with entities like MOGAD, we are still learning what the optimal treatment regimens might be, and that we need to continue to do research in this area, collect data. And I think it's really critical in a venue like this to understand that collecting data from different countries, I think, may show us that the optimal treatment outcomes may differ in different populations. I think that's an area that we still are lacking knowledge. And then finally, we have continued challenges in our treatments of serious diseases like traumatic optic neuropathy. And I'm hopeful that both in terms of research like Dr. Mahesh is doing, as well as preventative efforts such that the incidence of things like traumatic optic neuropathy goes down, would really be pushed forward.
Thank you. Thank you so much. Big thank you to all the panelists and all our speakers. Thank you for sparing your time and being here today. And big thank you to AIOS as well for having us and having this session. Thank you so much, and have